For the members of the committee, I apologize for the delay. I had overlapping meetings and the other one I needed to attend also. So the only way I could do this is virtually and missing a bit of this one. But anyway, we have had the Acute Psychiatric Committee and the Human Services Committee meetings last week in Fargo. And actually the week before, time flies. And so what I'm going to do is just hit a few of the highlights. First of all, we'll talk, I'm going to get the acute psychiatric one out, it's a little shorter. But with the goal of the Acute Psychiatric Committee was to determine what the appropriate amount of money or proposal might be to present to the legislative body in January for a new state hospital. The state hospital and the oldest building on the UND campus are the only two state-owned buildings that predate statehood, which was 1889, as most of you know. And so it was built at a very different time at a time when care was an entirely different thing. So we need to do it new for a lot of reasons. But Representative Robin Weiss and I were asked to be kind of ex officio members because the original committee was all appropriators except for one. And they felt there needed to be some input from the policy people because he's chair in the House and I am chair in the Senate of the Human Services Committee. Because it also includes what's going to be going on with services to be provided, including short-term residential stabilization and assessment locations as one of the considerations throughout the rest of the state. So people can be closer to home if they're going to be getting treatment. Anyway, at that, I had asked Representative Nelson if he would have Dean Wynn, Dr. Josh Wynn from Grand Forks, who's the Dean of the Medical School of Medicine and Health Sciences, to share with the committee the way the process went when the new medical school was built, because I think the process worked well. And so he did a really fine job of that. And I'm not going to go through all the details because, quite frankly, what Elisa and I are going to tell you is that the best way to see this stuff is to go on the legislative website. You can see the agenda, you can read the minutes, you can read all the attachments, you can watch any of it virtually, all or any part of it. Just look at the agenda, see what time it is, and skip forward to that place on the video, because that's the best way for you to be doing this, not for us to give you too much detail. But among the things that Dr. Wynn talked about was the fact that there's a medical school advisory council, which is made up of a variety of stakeholders, 2 legislators, 1 from each house, and then providers as well, and any number of people who are appropriate for that, and that's in statute. And they had come to the Human Services Committee, well, I don't know, 10 years ago now, I suppose. If I looked at his notes, he would tell me, to talk about what we need to do with a new medical school. And they had already visited with an architect, the architects, about how they might do this, and they have more than one proposal. And one was to just update what was the St. Michael's Hospital and was being used as a medical school building. The second proposal was to keep that St. Michael's Hospital building and add on to it. And the third one was a new building. Well, we asked that advisory council if they would be willing, because we can't tell them what to do, we can only ask them what to do, if they would be willing to vet these 3 proposals and let us know what the advantages and disadvantages of each might be. And they said that they would do that, and it was wonderful because they showed us very clearly that the answer was the new building, which we already know that in the state hospital. But what I wanted this committee to know was how that process had evolved. And so what Dr. Wynn was sharing with us is the fact that it was, they had advice from the Medical Association, the Medical School Advisory Council. And they were all advocates, but they were not a part of the medical school. And that was an important thing. So it's an independent body. And I think that's important to know. And then they had vetted this with the help of the architect, who was an outside expert in this kind of thing, because they really are. to talk about what structural components might make it work in the best way possible. And then moved it forward after they had put all of these things together and gone through it. And it was clear to the Human Services Committee at that time, or Healthcare Committee at that time, that the best option was the medical school. Yes, the initial cost was more than updating the old building, but it was going to last for a lot longer time. It was going to be useful longer. The energy costs were going to be significantly less. There weren't going to be the same kinds of maintenance costs, and the IT was going to be darn near impossible to put the way it needed to be in the old building. So I really do want to see that same kind of process used for this state hospital building, not have somebody just come and say, I think you should use this plan, because it's too big a deal. So anyway, that's one of the things that came up in the acute psychiatric committee was this vetting, and a really excellent proposal. There was a PowerPoint presentation from Dr. Wynn that I would recommend you take a look at if you are interested in knowing more details about that. At that acute psychiatric meeting, we also heard from Jeff Herman, who's the CEO at Prairie St. John's, about their new building, and from Eltrue Hospital in Grand Forks about how they're expanding inpatient behavioral health services, which was good to hear as well. And let's see, I'm moving right along here. We had some other community people who spoke also about the need for community behavioral health, including Mayor Tim Mahoney in Fargo, the police chief here, Chief Zwolski, and Arlette Preston, who's the city commissioner. Ty Hagelin from Chairhouse and Shobin Depa also commented at that meeting. We moved on then just for implementation of the expanded behavioral health studies. And there is from the children's, whoops, that was in the other committee. I got to get rid of those papers here. Oh, and I want to say in the Dr. Wynn's one, I'm sorry, I just walked in the door and had to get a verification code to get into the team system today for the first time in a few days. So a study of needs as well. So as I mentioned, the advisory council, that was not school. The initial study, which was $100,000 to hire somebody to do that, about the workforce needs, educating more students, and how do you do that. Then the study of needs, how the rooms were, but being done by people not directly affected, but by experts. But in the Department of Health and Human Services, the status of the bed management system, that was discussed, and that is up and running. What that means is that every day at a single point in time, there will be a report from every facility that has behavioral health beds available to the Department of Health and Human Services, how many beds, if any, they have available at that time. And the good thing about that is there'll be at only a point in time, but it'll be every day. There'll be a report on that. So if somebody, for example, Williston Law Enforcement had a really bad example of this a couple of years ago, in which they had someone who needed an assessment, and it was determined that they really needed to be hospitalized, and there are no beds in Williston for that purpose. And they had called Bismarck, and they said there was a bed. By the time they got there, a Bismarck person occupied it. They called Fargo. Yes, there was a bed. By the time they got there, it was occupied, and they drove back to Williston, and the individual ended up in jail. Well, we don't want the person there if that's not the right place. So now they'll be able to call ahead and reserve a room. The room will be there for them when they get there, and that, I think, is an important thing. And we also talked about the individuals who have now become eligible for services because the HUDA score, that's the World Health Organization Disability Assessment Schedule score requirements, have been reduced, and so that's going to make more eligible individuals for some of those services. We also heard about the mental health registry, which is up and running, which is registering every individual in North Dakota that's a provider, and they just do that once a year, and they'll remain there, but they just need to say every year, yeah, I'm still at the same place, or I'm doing it independently, or whatever. Because the facilities are not all recognized in the same way as the individuals. Obviously, the board recognizes the individuals who are counselors, the appropriate counseling licensure board, but they don't share that information with anybody else. So this enables the Department of Health and Human Services to know where all the providers are located, so that we might be able to have easier access for individuals in the rural areas also. And then we discussed also how they are working to integrate that into the 211 crisis system too. And then what kind of ties in with that also is 988 with the new suicide number that is out there as well. And there are the recommendations from the HSRI, the Human Services Research Institute report, and the 2022 Renee Schulte report were also discussed. And let's see, moving right. We are going to be doing some additional work on the services for individuals who are incarcerated. Excuse me. And the Cass County Jail, for example, has a mental health licensed mental health provider on staff, but not very many places do. And all of the services that are needed are not available just through her. So we're going to be looking closely at what we can do to meet those needs better. And the Board of Addiction Counselor Examiners talked about reciprocity with individuals licensed in Canada and being able to be licensed here. I had a conversation this morning about some of those license transfers, also including background checks, which are sometimes viewed differently as far as the amount of time that it's taking, and it's taking more time than some people will think it does. But we're working on that as well. Turns out that the feds have some rules about slightly different background checks for slightly different services. For example, if you are licensed as a certified nurse assistant, you have a background check that's done in order to be employed there. But if you'd like to go work in a child care facility, you have to go have another background check, even though you're dealing with a vulnerable person in each case. And it's a slightly different requirement. So then they have to do that all over again. And I met this morning with someone who's the biggest child care provider in North Dakota at the Y here in Fargo. 2,300 kids are under their supervision in various sites. And they're just, it gets to be a real problem with how this gets managed. And we find that part of the delay is from other states. We could do the in-state people really quite quickly. But if somebody is licensed or is moving in from another state or another country, we have a lot of new Americans applying here, it takes a long time to get the data that is required. So there's going to be more discussion about that as well, of course. Social work examiners, we talked about them having access to IT, state IT. They really desperately do need updating of their process. It isn't a good online process. It's not quite a yellow pad and a number 2 pencil, but kind of they're good people not bringing things up to date. And we reviewed several different bills that were being discussed, several of which were introduced by Senator Mathern, but not discussed in the committee. He may or may not introduce them during the session, but he just brought them to our attention. And let's see if I missed anything there. Oh, that one of the things is a bill which will move forward to allow $2 million to demolish the unused buildings on the state hospital campus. That was authorized 6 years ago, and it hasn't been done. And it needs to be done. And in this case, the bill will say that there can't be any money spent on a new facility until the old stuff is taken down. And there's been some resistance to taking down the old buildings. The historical impact of those buildings is not something we necessarily need to preserve. They're not unique and interesting for a lot of different reasons, but the space is needed in order to do better things with the facility. And another one that would enable the human service centers to contract with private behavioral health care providers to provide acute psychiatric treatment and substance use disorder treatment if the services are unavailable at that particular human service center. They've been enabled to do that, but now it would be a requirement that they do that. And also, this bill that would move forward would require the human service centers to become certified community behavioral health clinics or to work towards that. So that would be a thing. We talked about having a social work compact. The people who wanted it, the person who wanted the social work board to work on that, it isn't something, quite frankly, that an individual board does. That comes from a national association of any profession, and all the ones that I've seen come through committee work that we've approved, and we have quite a few. It comes from the National Association, which has brought together people from many states and sent out proofs of certain things that they're looking at, and they get feedback from all the states, and they're able to put together something that has consensus when they do. So they can be encouraged to talk to their national association, but that's a better direction for that to go. And then we also had a chance to tour the new Prairie St. John's Hospital. It's not quite done yet, but it's going to be a very nice facility and really kind of a state-of-the-art facility that's providing psychiatric services. So, Alisa, do you have anything else to add about that?
Oh, Senator, thank you. Can you hear me?
Yes.
Yeah.
Yeah. So, no, you're doing a great job. I appreciate the good overview. So I will let you continue.
Well, and I wasn't trying to steal Representative Miscogg's job here, but she had a very busy weekend between work and campaigning and family responsibilities that needed to be addressed. And it isn't that I was sitting around eating bonbons, but I had a little time one night to at least put a few notes together from the agenda because we don't have the minutes yet. So anyway, thanks, Alyssa, for going through it with me and thinking that what we were talking about was okay. All right, we'll move to the Human Services Committee. We had one of the items on the agenda was the study of the services of the programs for individuals with developmental disabilities and autism. So we heard reports on that. And then, let's see. Okay. And that was just an update on how things are going. The study results were approved. Employment restrictions and public assistance program, that's dealing with the benefits cliff. And that bill was approved to move forward, which would enable a higher amount of income for temporary assistance for needy families who are applying for benefits. And temporary assistance to needy families was developed as part of the Welfare to Work program in 1997. And in that, an individual, it wasn't always a single parent, but let me just use that as an example. It might be a mom with one or two children. And so she was needing to have benefits in order to make things work. So with this program, Welfare to Work was intended to help people become independent by helping them move up the ladder a bit on their income. So they could have a year of college. It could be finishing a 4-year program or doing a 2-year program or whatever, but one year is what would be paid. They'd have childcare provided. They'd have health care provided. They could have a decent car because it turns out that there was a small dollar limit on their cars and they were never reliable when there hardly any value left. And maybe grandma was willing to give her car to this young mom when she bought a new car and she couldn't take it under the old rules. So we eliminated a bunch of that stuff. And there was also cash payment. The agreement was that there would be no additional cash payment for any additional children born into this family. And so occasionally we would hear about that, and my standing remark to people who are critical of providing this kind of support to individuals in this position is, you think what we're doing is serving single moms who are drinking beer, smoking cigarettes, and standing around not working, and they're having more babies to have more money. I said, you couldn't be farther off in what you think. Because you know how much money somebody got for an additional child before TANF went in? $64 a month. I don't know anybody foolish enough to intentionally have another child for $64 a month in income. It isn't worth it. So anyway, the program was very successful, teaching people how to write resumes, how to apply for work. They needed to go and make applications for jobs. And so the whole program was intended to nurture them through this process. So we had a little concern at the time about whether or not people were going to age out of this. The feds, and it's still in place, has a 5-year lifetime limit on getting cash benefits. So we were concerned about how that was going to go. Well, we checked about a year ago, and it's either 0 or 1 person who actually got to the 5-year period. The rest were able to be independent, and they may have had a couple of other services that they benefited from. They might have gotten healthcare benefits through CHIP, or they might have had other kinds of things, but they were no longer on the cash benefits program. They were able to make their way independently, and we were really pleased to know as we went along how that was going. So anyway, that was a good thing to hear a little bit more about. We're still talking about the compensation for employees in the zones. As you may recall, 53 counties were turned into 19 human service zones. 4 of the big towns in North Dakota are individual county zones. I don't know that I would do that again now, looking back at it, because Burley and Cass have struggled with that. They thought everything would be the same, and it isn't supposed to be. Minot and Grand Forks have done okay, but they're getting it worked out. So anyway, there are things that need to be more streamlined in order to let people who have degrees in social work do counseling instead of paperwork administering another level. And so it's really gone well, and the counties have worked hard on this, and they worked with us in developing this plan. But the compensation issue is interesting because some of the people working in those offices are state employees and some of them are zone employees, and they're not paid the same, or the benefits might not be the same. In addition to that, once one gets into it, it can be between the 2 counties in a zone. For example, Hillsborough is in Trail County, right? Yes. Their program gives individual health care to the employee because they have the most bridges of any county in the state, and they don't want to overtax their people too much, and they've got to take care of the farm to market roads and all. So they do individual health coverage. The other county, which is the one to the west, Alyssa, do you remember what it is? It doesn't matter. Anyway, the one to the west of Trail, west of Hillsborough, they're the other one in the zone, and they give family coverage. So that's obviously not fair because that's the way it works out. So they have to decide what they're going to be doing within the zone, and that zone advisory committee and the board that runs it then must submit their budget to the state, and they will be reimbursed for whatever the zone decides it's going to do. But there also is a difference between state employees in some of those facilities and the ones who are working in the capital, never mind other zones. So it's between the counties in a zone, it's between zones, and it's between the zones and the state. And we need a consultant for it, and we're going to have to put some money into it. It got more complicated than we thought. It needs to be fair, there's no doubt. Guardian Services, we had a really good presentation in the Human Services Committee from Guardians. I've had a good conversation with Guardians about the need for more of them, obviously. I know that Cynthia Phelan is doing a work group, as she did, I think, 4 years ago. She ended up with a kind of a big bureaucratic solution to it to establish how guardianships could be run. And that was dead on arrival because it was paying a lot of money for another committee and office, and it didn't provide any additional services. There are better ways for us to do that. So there will be probably a couple of bills coming in. And Senator Heckman had been the chair of the Children's Cabinet, and she did a wonderful job of telling us what their work was. They've met every month. They've done a tremendous amount of work, and we have a bill now that will be moved forward that will okay some of the things. There was nothing radical in it, but to make sure that the governing of this, or the work, I should say, they don't govern anything. The work of this Children's Cabinet and making sure that they are providing properly enables them to do proper work in advocating for services for children who are not involved with criminal justice. And so that should be a slam dunk in the session, not a problem there. She just did a wonderful job. Basic care rates were revisited. That doesn't really affect Olmstead at all either. We're looking at more and more programs for home and community-based services for older adults. And the facilities that are in the state, the skilled nursing facilities, are recognizing that need themselves. They are looking at adjusting double beds into single bedrooms because that's what most people want. And that is an important thing. But also PACE, which is a program for all-inclusive care for the elderly. There's a system up and running. It has been for quite a while in Bismarck. It does a great job. It's kind of like a day services program for older adults that includes availability of medical attention, of counseling, of therapy, of activities for people who might have dementia or whatever, but they can still go home, but there's nobody there that could be with them during the day. And then there's another one that is being proposed by Blue Cross Blue Shield, which of course has Medicaid expansion now. And they are looking at one for dual eligibles, Medicare and Medicaid. That also would enable them to have better care provided in a home environment rather than in a skilled care facility, which in the long run is likely to also be less expensive. So it's very good to hear those two programs. And then Jennifer Illich from First Link came to talk about what's going on with First Link. And of course, they're the ones who run the 211 number. 1 minute of history on that. That was originally a wholly owned program of the United Way of Cass Clay. Lake County, Minnesota, and Cass, North Dakota. And it was run out of their office. I remember when it was there. But Minnesota had some change in their tax law, so First Link or United Way could no longer have a wholly owned program. They had to throw it off as a 501c3, so that's what it's been now for some time. But they serve the whole state now. They serve the whole state of North Dakota plus Lake County. And we have got to do a better job of funding them for that, because all of that funding can't come from money that's been raised through charitable contributions or contributions from this community, because 60,000 people, I believe they said, were served, something like that last year. They also are, of course, handling suicide calls. They are the only trained and certified as suicide call answerers in the state, and all of those calls go to the staff that's there, both with 988 and with 211. So it's certainly something that needs our support there as well. We had a little report on the newly integrated Department of Health and Human Services. That was official as of September 1, and it's going well. And so Chris Jones is commissioner of DHHS, and Dr. Wiebe, who is a state health officer, is head of the health division of DHHS. He is still a member of the governor's cabinet. He is in charge of everything there, but he doesn't have to do the administrative work, which has to be done in the health department. So Department of Human Services has 2,265 employees, and the Department of Health had 210. So it kind of made sense to sort of plug and play the Department of Health into DHS and make it the Department of Health and Human Services, and just have them do the health stuff. And that's the way it is. And Dr. Wiebe is certainly an important provider of leadership in that health area. Then we actually toured the Family Health Care Center in Fargo, and if any of you have not, I would encourage you to do it sometime. It's the largest federally qualified healthcare center in the state by far. They did have something like 40,000. You remember, Elisa? Was it 40,000 visits? More than that last year, with 13,000 unique patients. And they're serving a very diverse and very important constituency. It isn't only uninsured people, but because there are people who would like to have them as their provider, and they go there because they choose to do that, and they have insurance. But it also is the first place that people come when they may be an immigrant or a refugee, in order to have that initial medical checkup that is provided by the U.S. government to make sure that everybody's healthy that's coming in. And Pat Gulbranson is the leader there. The director of the Family Health Care Center does a wonderful job. And I think the committee was very impressed with what they had to see. And hopefully we can expand those services. There's a higher federal reimbursement for them. So I have, for some time, wanted one in Bismarck, for example. I can't imagine that we didn't have one. The doctors thought this for a while. Some years ago, they thought it was going to be competition for them. Well, heck, these are people with no money. So how much more uncompensated care do you want? So let's get an FQHC in there that can help provide those services in the very best way. And we have loan repayment programs for the docs and nurses. They have 10 dental sites, for example, here, 5 in North Dakota, 5 in Minnesota. And there are people that come from all over the region for that, for dental care, not just medical care. So it's one of the few places that you can get dental care, and it will be provided without any question that Medicaid reimbursement will cover. So anyway, there were changes to the field service units. So you aren't going to necessarily care a whole lot about this, but the flow chart of the way you run responsibilities. The flow chart for DHHS that shows the responsibilities of all of the officers. Rosalie Etherington is going to be director of the state hospital, as she has been for some time, but she'll no longer be in charge of the human service centers. That will fall under Pam Sagnus's bailiwick, and she has visited all the human service centers and several of the zones in taking over this. She wants to visit with the people who on the ground who are doing the work, and I think that's really good. So that's pretty much it. If you have any questions, I'll try to answer them.
Thank you for such a nice overview. I was thinking, if you don't mind me saying it, that your presentation also is a good argument against term limits.
Exactly.
Thank you. May I add, because I just thought of this yesterday, because I have the data, I'm not going to bore you with all the numbers, but of the 15 states that have term limits, by the way, 6 have had them and have turned them away again. We are the only ones that have 80 days every other year. So if you take 80 days every other year and 2 4-year terms, that means there's a total of 320 days in the legislature maximum. That's not even 1 year. You really want somebody there who has only been there for less than a year, and then you got a new person in there again? I'm just saying, there's got to be a little history with some of this. I'm not looking to be there forever, and I won't be. But this is health and human services is so extremely complex that you've got to let somebody kind of get into the weeds with it before they can understand about it. And appropriations wants the policy people to know what's going on because they rely on us. I mean, we work in the Senate, and Alyssa can comment on the House. I'm sure John Nelson is appreciated by his appropriations committee there when he comes back with the human services sections report too. But we work closely all the time with appropes because we don't have sections to do it the way the House does. Their whole committee hears every bill. So there's got to be somebody who knows what's going on. And those folks ask us, not just me, but ask us that are on the Human Services Committee, what's happening. And I find that nobody has any trouble getting a hold of me because I don't like a messy desk. And I can hardly find mine now. I have so many notes about people who need to have something done. And the day just isn't long enough to cover all that stuff, never mind having an election coming up. So you're getting your money's worth out of me, folks. 10 cents an hour.
Thank you very much. Now, are there questions from the commission? That was a lot of material to be covered, and appreciate that.
The only thing that I would add, Wally, is that I'm really serious about the best reference, rather than having reports from anybody in this committee. I would encourage people to go to the legislative website, legis.nd.gov, legis.nd.gov. And there is so much on that homepage there. The calendar is there. You can forward to the next month. You can see what committees are scheduled. You can click on the committee, and if the agenda is available, it'll be up. It's always available before the meeting starts, but it's not done the day the date is posted because we want people to reserve the date, and then the agenda will follow. So please take a look at that. The information about all of the legislators, everybody's contact information is also available there. Just click on the appropriate legislative assembly and you'll get the whole list, and you can get House or Senate or whatever you want, or the whole batch. You can listen to the entire meetings of all of these committee hearings that we've had anytime. If you have insomnia, feel free in the middle of the night. But the other thing is that you can also look at the agenda and see, oh, that thing I really wanted to hear about is at 11:30. Okay, then you can fast forward, so to speak, on that video, and you can see because we try to be close. We're never perfect, but you can watch just the part that you're especially interested in, and not spend the whole 5 or 6 hours, or 7 sometimes, going over this stuff. So please do look at that. That's where the expertise is. It would have been nice. I know Daniel would have been happy to pass out written material if I had had time to provide any for you. But you're way better served by going to read what the minutes are for those 2 meetings, because that's their job, is to put everything in good form, and it'll be more complete than what I have been able to give you. And I think that would serve you well. So just please pay attention to that calendar, what the agendas are, and when the committee meetings are. And of course, the same will be true during the session too.
Well, I know as you gave those references, I was taking them down because I think that's just excellent. You were talking about Dr. Wynn and a few other things I wanted to see.
I'd really encourage you to watch that one. And in particular, there was no bad stuff there. There was a lot of good stuff, and neither of them was terribly long in this case, because each of us had a tour. Human Services saw the Family Healthcare Center, and Acute Psychiatric saw the new Prairie St. John's, which you did not get in the tour because it's under construction. You're looking at sheetrock and countertops that are in, but closets that aren't done and stuff. But we got to see what the layout was, and that's terrific.
Just a quick question for you on the state hospital. Is that constitutionally protected to be in Jamestown? Is that how that works? Or
Yes. So there has to be a state hospital in Jamestown, but it doesn't have to be the only facility. And that's why it's kind of important for Robin and me to be involved, or any other policy people. They just asked the 2 chairs, because we're talking about how to best provide services in the rural parts of the state. without violating the IMD exclusion, that crummy federal limit that says there can only be 16 beds in a facility. We're not talking long-term hospitalization here. We're talking shorter-term ability to make sure that somebody is able to be stabilized, that they can be assessed, that they can see if medications are appropriate for the individual, if there should be some, and get them on a plan that kind of works, then move them out into the community so that they can have counseling. Well, their family can be involved if we're in a rural area as well, or any area besides not only Jamestown, but include family in the care. It's parallel to what we were doing with the substance use disorder voucher, where you can go any place there's a provider and get care. We want it to be similar to that. But there needs to be the ability to have, in some cases, it might be just a few weeks, but there are cases. I had somebody this week talk to me about someone whose son is a strong schizophrenic, and he's just had a real difficult problem for quite some time. I have some friends in Fargo, and their son developed a bipolar condition, and he's maybe 30, and it's been really critical, and they had to call the police one night because they felt unsafe. He was now living at home because he couldn't work anymore. And they had to call the police because he was threatening them. And, it's heartbreaking for them. We've got to figure out a way to be able to bring someone to a spot that is a calming spot with professionals there to help them to work with others, including their families, hopefully, to stabilize, to be a part of the solution to be able to help manage their own condition, to assess that medication need and management, and be able to leave and move out into perhaps a secondary site where they could live in an apartment and work at least part-time and be able to come in for counseling every day as it was needed, and then less often. But we want them to be launched, but it's got to be a gentle launch. We can't throw them into the lake, and but it is not financially sustainable when you can only build 16 beds. And Heartview in Mandan is making it work with one additional site in Dickinson and one in Candu, because they're far enough apart that the feds say it's okay, because they don't have the same staff counselors and so forth. They don't have the same medical director, and they don't have the same board of directors. But I'm going to use Fargo. If we're in Fargo, Sharehouse wanted to purchase an apartment building that was next to their main place there, so that those who are living in the community, going to work part-time and then come in for counseling, that they could make use of the services of the counselors that are already part of the staff. And they were denied because it's too close, and they will be using the same staff. We're never going to go back to that terrible institutionalization. We're not even, there's no discussion of that. I mean, that's way past. So to not allow us to be able to do something that is financially sustainable, but still individual care, is making me a little crabby. And it is others too, but this federal IMD exclusion, it is the only treatment compensated by Medicaid in which the decision about whether or not Medicaid will reimburse for the service is determined by the size of the facility in which the treatment is given. That is dumb, in my opinion. Feel free to disagree. But we just can't, if we can't have two facilities in the same town who might share counselors, but are entirely separate and are trying to do all the other things to make sure it's a much more individualized setting, we can't make it work. You can't. No, financially, it has to. Yes, I just had the same chat about childcare this morning. So, it's a problem in lots of different areas. But that IMD exclusion is a challenge. But anyway, that's maybe all we need to talk about on that one. Unless you got something else in mind.
I've got one other question for you, and then maybe the other commission members might as well. But one of the things when you're talking about beds that are devoted to certain treatments, one of the things in talking to a hospital administrator recently, it's not beds anymore, it's nurses, isn't it? I mean, who
totally. Yeah, staff and counselors, everything. I mean, there is I was at Aldevron yesterday, and they're paying extraordinarily wonderful salaries to bright young people coming in working on biomedicine. And they're shorter people too. So the point is, it's not even money. We don't have enough bodies. You know, people aren't having 10 kids anymore. So it's really a challenge no matter what, whether you're trying to find somebody to work restaurant service or CNAs in a nursing home or a hospital or childcare providers or high-end jobs. We don't have enough people. And I don't know how we solve that unless we decide we're going to loosen up on legal immigration, not illegal immigration, but legal immigration, and allow more of the people to come in who are looking forward to living in this country for all the right reasons, and we would like to have them here, and they can't come right now, and that's just plain foolish. And I'm beating up on both administrations because two of them have done it. So I'm not even being partisan about it. I'm beating up on both of them.
Thank you so much. Is there others that would like to?
Surely. Senator, thank you very much for the really good kind of overview, but if I could draw you back to the beginning where you just lightly touched on the A&M study and tell us a little bit more along those lines with the DHS bill and kind of the interim committee's take on that.
And to talk about what? About which committee and which topic again?
Human Service Committee and the Alvarez-Marcel study on the IADD ASD services.
Do you want to introduce yourself?
Oh, this is
Yeah,
Brittany Armstrong Hansen in the back.
It's who?
Brittany Armstrong Hansen. I'm a parent and a member of the DD Council.
Oh, are you?
I was told to introduce myself.
No, but are you
I'm
on
sorry.
the Olmstead Commission?
I'm here as a public comment today, or public.
Okay, just checking. I think it would be best if you would go online and see what the report is, because I don't have all the details of what that was available to me here. And that would be the best. It's not the only, I'm not trying to cop out on you at all, but the discussion was there, and you will benefit from just going online and watching that portion of the committee activity. That was at 9:05 on the morning of October 6th for the Human Services Committee, and went on for about 40 minutes, maybe 30 minutes or so. And it talked about both the developmental disabilities and autism programs. And what we really were talking about wasn't so much the study as it was the fact that there were going to be some bill drafts. And one of them was this Cross-Ability Advisory Council, which would talk about making sure that we don't have sort of silos of services, but rather that levels of care are kind of going together. Contracts with a facilitator to also provide support services. And there would be that was for this advisory council. And then 15 voting members, majority would be family members of individuals or an individual with a disability and who receive medical assistance, home and community-based services. And the remaining members must be appointed based on professional expertise and knowledge. But those bill drafts are there entirely. They are links in the agenda and will be totally in the minutes when the minutes are there, which I don't have yet, but they should be available in the very next few days, because these meetings end up with lots of stuff in them. And so the clerks are busy making sure that everything is in them that there ought to be. And we have a couple of really great clerks in both acute psychiatric and in human services, and they do a great job with it. But when the minutes come out, the chairs get a chance to review them and make sure they're okay, and then they go out for everybody, for the committee and for the general public to see. So everything that we see, you can see too. But that would by far be the best. I don't want to shortchange you by not telling you all about it, and I don't want to read these bills to you. And I've only got a couple of them that I printed out, because the rest I've got in my computer. I don't have them in my head.
Thank you. Actually, yeah, I have read them and what's available to me, but I was just felt like the commission maybe needed to hear a little bit of it, and particularly drawing attention to that cross-disability council that may be constructed, and then looping back to you talking about background checks and kind of a reciprocity situation and the duplication of service. With that, on that same theory, we have a number of advisory councils already in the state that would address the populations that would be served for that cross-disability, and I just kind of wanted to have some commentary on that.
All of that will be appropriate discussion when the bill is brought to whatever committee it's assigned to, most likely Human Services, and that'll be part of the hearing. So that'll be a good time to bring that up. I don't have any more information than that for you, because all I've got is what the person who drafted the bill said about it. We didn't discuss whether or not Because the purpose of our interim committees is not to do that. And it is certainly not actually, in my opinion, of the Olmstead Commission to discuss it at this point either, because it hasn't even been a bill that's been presented yet. So when the legislative session starts and the bill is heard, that's a wonderful time to come and present whatever concerns and thoughts that you have or support. And then it'll be part of the discussion at that time. And that's when those bills will be vetted and it'll be decided whether or not they will move forward in one shape or the other.
Right, well, you've given us the better part of an hour, Senator, and we certainly appreciate it. We've got some more business to cover before our time is up today, but thank you again. And Representative Minskog, if there's any final points you'd like to make, please do.
No, Senator Lee did a great overview, and I think what she's just demonstrated, that the whole term limit issue is, I'm coming off my first interim committee on human services. I had one committee or session under my belt for appropriations for human services. There's a lot to learn, a lot to take in, and Senator Lee has worked for several years in this area and is, in my opinion, an expert in the legislature. And we're so fortunate to have her serving on the Olmstead Commission. But I, again, would echo and encourage the commission and other members of the public, please go to the North Dakota Legislative website. The committee meetings, interim committee meetings have been videoed and archived, so you can play back the testimony, and there's so much information to be gained by that, and as well as the minutes, and the reports that are submitted and testimony. So I would just encourage, if there's any questions on any particular areas, then I would encourage you to reach out and log on to the legislative website. But thank you, Senator Lee, for the great job and overview of the two interim committees.
Thanks for your help, Alyssa.
Thank you both, so appreciate that. We need now to go to item 6, which is the follow-up on the autism spectrum disorder inquiry, the ASD.
Thank you. I had submitted a request for some additional data to Tina Bay from the DD division. Unfortunately, it looks like it may take her some additional time to provide the numbers that we had asked for. Also, I have a call scheduled with Heather Jenkins, but her schedule didn't allow her to be, for us to speak until sometime after this meeting. I've also contacted the NDACP, the Association of Community Providers. Some of the information that was relayed by Jessica and Tina and Heather when they were here for the last meeting indicated that they occasionally had problems placing people out of the LSTC. It was a real challenge to find placements for people, especially high acuity. And I invited them to speak at this meeting. They essentially indicated that the workforce struggles that everyone had identified previously are really an integral part of why they're not able to accept more downstream needs for everyone. So I think we can have a further follow-up at the next meeting, but it also may bear some investigation or inquiry as to, what I think the senator actually may be able to bring something to the table, because she's on a task force or work group that's working on behavioral health workforce. Talking to Angela and Lorena from the Associated Community Providers, they just had a one-word answer to why they couldn't do more, and that was workforce.
Mr. Chair, if I might make one comment, and that is that I saw some information this week, just a short-term message of one sort or another. The majority of those individuals who are being served in the Life Skills and Transition Center, it's a turning number, but the ones that have been there longer are seriously behaviorally challenged, and including sexually aggressive. And it's very hard to find community settings for somebody that is going to be risking the other people's health and safety, whether it's staff or another resident. And so that becomes a special challenge for staffing, because you often will need two people at a time in caring for this individual. And so it will be a continuing issue, and we need to recognize that some people are perhaps so at risk of having outbursts that will be dangerous to themselves or others. That having them in a place where professionals are always there is not a terrible thing for that, at least for the time being, until there's some other way to do this. So nothing is ever perfect. And so we just have to make it as good as it can be. And it's definitely a staffing issue in every single facility. I'm meeting with folks in one of the group homes tomorrow. I think it's tomorrow. I look at my calendar. Because they're wrestling with it. And we've got all kinds of childcare providers that can't fill the trips, so to speak, because they don't have enough staff to work there, and money isn't even in it. Back to Bobby. So yeah, staffing is it.
Thank you for that.
There's another comment from
Dan, if you, is there another?
Senator, did you have another comment?
No, I was trying to take my hand down, is what I was trying to do. There. Is it down now? I hope
Down.
so. Okay, thank you.
Any other comments in regard to that? Yes.
I have a comment for the commission specifically. A number of things that were said repeatedly today. So the difficulty of moving individuals out of LSTC into community, providers not accepting them because there's a higher staffing need or there's a workforce issue. But that's something I think should be at the top of everything that's being discussed or on the mind of the commission to urge information, studies, God forbid another study, but information and energy directed towards workforce in that light. What is the department doing to support new providers to come in? I've had some feedback from fairly new DD providers that there was minimal support in policy writing and getting licensed and getting up and running. That could be something that could be addressed and, with some push. And then if it's difficulty moving out, targeting what is lacking in the community settings to move these individuals out. Is it the rural environment, staffing, the workforce issue that we typically encounter? Is it specific services? Is it the SIS assessment? Is it, what is it? If we don't know what it is, we can't address it. And the what it is a big part. Going back to how many beds and long-term residents, if there's not a legal reason for these individuals to be in an institutionalized setting, as in incarceration, they should not be limited to that living environment. We should be working hard to figure out what is working at LSTC and find a way to duplicate that in the community, whichever community it is that those individuals came from or want to return to. That's
talking.
Brittany Armstrong Hansen from Bismarck. So that was just, it's been touched on even in the minutes. 82% were harm to others as the reason for admission or readmission. What has been done to look into, was it actual harm to others? Was it risk of harm to others? What interventions took place in what setting? And again, if the risk and harm is, the actual harm and the risk is not there at LSTC because of what they're doing, what are we doing as a state to duplicate that in the community?
We certainly over the last number of quarterly meetings been addressing as much of that as we can, but you're right to point the challenge out there.
And if that is a concern that the commission has, I've been speaking to Heather Jenkins. There is a transitional task force that they're putting together to discuss, what needs to be in place to move people out of LSTC in a sort of intentional fashion, and I can bring back to the commission a report on what that workforce task force is going over.
I'd have one more question for Heather too. In the past, they talked about the CARES team being more of,
Please identify yourselves.
this is Julie Hornsvet. The CARES team being able to like go out and provide training to providers to provide those supports in the community, kind of being like to bring those skills that they know over how they respond to individuals that are at LSTC. This was years ago, but I still think it might be a good model to think about for supporting community providers so they can provide those supports to people where they live at the time, kind of like crisis outreach. So if that could be another thing we could revisit with them. I know the DD Council was really interested in that a while ago, and I think it'd still be a good thing for us to bring back again.
This is Carlotta, and in realms of there being a crisis situation, mental health issues for individuals with developmental disabilities in the community, I've been told by the Department of Human Services that in fact all individuals should be able to be using the mobile crisis units as well that are throughout the state. And I don't know if we've done a very good job of letting the DD community know that that is available for those folks that are having those crises, that they can come in and help de-escalate that. And oftentimes I would think that might also be able to help maintain their living arrangement that they have without going into more restrictive care.
Yeah.
So I think sometimes the different, when you have, again, siloed, when you have something in mental health and behavioral health, they said 100% of people at Life Skills and Transition Center, 100% of them are dealing with behavioral health issues. Yeah. And that's probably the majority of what is happening. So in the community, to keep people from going, we should really be making sure that they're able to utilize the mobile crisis unit. There's nothing preventing them, but making sure that they're aware that they can have that mobile crisis unit come out to them as well. Because the CARES team, I mean, it's great, but I don't know that it's as immediate as a mobile crisis unit would be.
Or possible dual diagnosis services.
Right.
I see Rebecca has a hand up question for us.
Yeah, I was just going to add, so Rebecca Quinn, that this very much mirrors the same discussion that happened in the Geropsych Services stakeholder meeting. I don't know if anybody was able to attend those, but same concerns regarding access to community-based care for those that are receiving care within Geropsych Services. Particularly the concern of the close to 1/3 of the population that is under the age of 65, to the point that even should they even be called geriatric psych services anymore when 1/3 of the population is non-geriatric. And lots of discussion about where better in community would we be serving these individuals, particularly since our geropsych services are in nursing facilities in the state. A lot of the individuals under the age of 65, it's not an appropriate placement. They don't have a peer group. So just wanted to add that it very much mirrors that same conversation happening on that end regarding individuals within those services as well. That need for a community-based behavioral health services for those that are also, have a neurological condition or a medical condition.
Thank you for all those comments. And maybe to close this particular issue, is there anything else anyone wants to add?
Can I?
Actually,
This is Nikki Maddock. I'm just here as a parent of a child with a disability. But I also have worked in healthcare and so worked in the lab and kind of understand how that looks on a day-to-day basis. So when you're talking about the bed reservation system, has there been communication with the hospitals of what it looks like for those 10 to 20 people sitting in the ER waiting for a bed and waiting for discharges in the morning? Like, has that conversation happened with healthcare about how some of those beds, even if you reserve them, there's people down in the ER waiting for beds too. So what does that look like for those waiting patients in the ER because we have nowhere to put them? until people get discharged in the morning. I just was wondering if that has been on your guys' radar at all.
I don't think she heard you identify yourself.
Yeah, can you repeat?
Oh, sorry. Nikki Maddock, a parent, but also worked in healthcare.
I'm not responsible for all of the resources that are being discussed, and frankly, those things need to be brought first to the hearings that are being discussed on these issues as they come to the legislature and to the department. Olmstead is not where this is supposed to start. It's where it may eventually end up if it doesn't all get done the way it needs to be. But there needs to be the wheel is going backwards here in the way the process is supposed to work. So please bring those notes and bring all those conversations to the hearings that will take place in January.
Sorry, Senator Judy Lee, I was not asking for like an actual yes, no. I just wanted to bring it up, and then just as I was sitting here thinking, like, that's going to be a barrier for that room reservation situation, especially for our individuals who do need psychiatric cares.
You're absolutely right. There's no question about that. I have a friend who had a heart attack in the emergency room at Essentia and was in a bed for 3 days in Essentia in the emergency room because they had no bed in the hospital. You're absolutely right. It's a
Very
challenge.
sad.
Yeah.
And I think, too, this is Brittany Hansen again. To Nikki's point, bringing things to light and emphasis for the commission, not necessarily asking for an answer from yourself, Senator Lee.
Yeah, this is one of our functions, is to be as well educated as we can be so that we're sensitive to all these issues. But
you're new to the party.
There's a plethora of issues.
And I think you're invited to this table, so we can hear you too.
Well,
Dan?
no, actually, Scott raised his hand.
Oh,
That's the second time.
Scott, have we missed you?
Hi, everybody. I'm sorry. I was going back and forth on whether or not to comment, but now that my hand was recognized, I will. And just to kind of, obviously one of the things that continues to be a function, or I'm sorry, a barrier is employee workforce issues. And that's a conversation that's being held at every employer basically in North Dakota right now. And the thing that I'm speaking very holistically when I say this, is for those of us in the room who care about issues regarding people and home and community-based services and whatnot, be at the table when those other conversations are being held as well. I can guarantee you the oil companies aren't shy about showing up at those tables, or the, egg industry or whatever it is. So we need to make sure that we show up and are part of that conversation as well, so that as policies are being made or as things are being talked about, that our issues are being thought about. And that's all I got.
Thank you, Scott. Appreciate it. I think we'll go on to the next item on the agenda concerning strategic planning, and maybe the report on the annual goals that the committee has come up with. Dan?
Thank you. I emailed out to everyone a copy of the annual goals that we had come up with during the strategic planning subcommittee's meetings. In general, the goals for what the Olmstead Commission should be doing are provide education, conduct research into issues such as service inequalities and barriers to integration, collect public input and incorporate that into the work of the Olmstead Commission, and receive and respond to directed inquiries, promote inclusion and participation of persons with lived experience in policymaking, and create awareness and maintain a public presence. Do any of the members that were not part of the subcommittee have a comment on those general goals?
As one of the members of that committee, I can tell you that what we were hoping to do is a little bit of what we're finding even at this meeting, what is our mission and what is ours to do? What is our role? And we tried to define it and coming up with, I guess, these seven various areas that we have been visiting and how we're going to do that. So in coming up with these strategic plan and the goals, we want to make sure that the commission is comfortable that we're addressing what this commission should be doing with one another. So as you look at what Dan just went over, we do an awful lot. We're talking about, we get a lot of education, and every meeting has at least a couple educational points. But then it's our job also to create awareness for the general public, and then do surveys, do whatever else is needed. But so we welcome. This is kind of a continuing process. I mean, this is something that can always be improved on. So as you look at what Dan has gone over with you, if you see something we're missing for the time being, let us know. And we, the commission, will put this on. The committee just is serving the commission to come up with what we think is a game plan for how the commission conducts itself.
As part of that discussion, the members of the subcommittee each contributed ideas on how better to enact those particular goals, such as provide timely public education on Olmstead-related issues via fact sheets or letters to the editor or white papers or special events or newsletters. And I have some preliminary goals for how often that should occur on the extreme right-hand column on this. Under conduct research, the two of the ideas that came forward were develop position papers or fact sheets on the 6 areas identified in the executive order, which would be community supports, education, employment, housing, and transportation, and identify best practices for each of the areas to address barriers and share solutions. That I think we can incorporate into my work plan for the rest of the year going into 2023. Collect and analyze public input. We came up with regular surveys assessing Olmstead Commission impact in areas of future interest. I pushed out an annual survey. We got responses. The responses have been downloaded off of Microsoft Forms and shared out to everyone. It's a lot of information. But I asked people to, download their suggestions on what would you suggest for us as a policy that you would put in place if you had all the power of the legislature. What would you suggest? And if you were identifying challenges or issues, what would you say that we should look at in housing or transportation, just to get people's input on where they see areas that we should, as the judge says, shine a light on how we're providing services. And the second part of that is provide an annual report to the governor, the Olmstead Commission, and the general public, detailing the work of the Olmstead Commission. Since we are a state border commission, we should probably indicate what we have been doing on an annual basis. Receive and respond to directed inquiries.
Dan, is this document something we can share for virtual people?
I'm sorry, forgive me.
Or presented?
In response to Julie's question, I will share my screen, which has the goal sheet that you've all been provided with. Receive and respond to directed inquiries. Receive inquiries, acknowledge, assess, and gather background information and present the subject to the Olmstead Commission. That is something that we have been discussing in an ongoing fashion, how to do. I have received some feedback from outside groups that for some individuals, it is challenging for them to go through that sort of process. Their interactions and their frustrations with receiving services, going through eligibility determinations, and the healthcare and behavioral healthcare needs of their families is enough of a traumatic situation that repeatedly volunteering that information and discussing that it ends up being a traumatic situation. And that's why they would prefer their stories to be told through some sort of larger organization where there are persons with shared lived experience, where they feel that it's a safer environment, a more nurturing environment. And quite frankly, I've had people say that they don't believe that the people that they're advising should be stepping forward to volunteer for this type of directed inquiry, simply because they're just not in a place where that is the best thing for them. And so I'm struggling a little bit in how to sort of balance the need for public information and private dignity. One of the things that's on the agenda is that I have received a request for an inquiry, but it is a person that would be discussing healthcare information. And so something that's on there is the need for executive sessions, just to say that the next time we come around to one of these meetings, there is somebody that wishes to bring forward an individual inquiry. I will be bringing the background information, and it probably will need, because of the confidentiality, to be in an executive session so that we can shut down the public comment and only have it be for the persons of the Olmstead Commission.
The other thing with what Dan's presenting is this really becomes his work plan for the year. So if you see other things that you'd like to see come out of our commission, and out of the work of our executive, that's what we're asking you to help us make sure that we're putting those on that work plan. Sort of not just our goals, but they're things we expect to see completed within the year.
And the next item after inquiries is promoting inclusion and participation of persons with lived experience in policymaking. I have this down as an ongoing goal to identify individuals with lived experience and encourage them to apply for various public entities to have their lived experience translate out into more of the larger world. I know that the DD Council has mentioned this as being something that they're interested in, and I hope that we can help support their efforts in some way. I know that a couple of the individuals that have come to this room as part of experiencing an Olmstead Commission meeting and providing public comment are interested in the second part, which is the recruit and charter a permanent advisory group of persons with lived experience. The advisory council that we discussed last time, I have 20 applications. Many of them are persons that I've touched during outreach efforts. I can pretty much vouch for them, but I would like a small subcommittee of volunteers from the Olmstead Commission to be willing to take a look at those that I don't know personally, or those that haven't been already vouched for by a member of the commission as part of their application. So that'll be one of the action items to come after this. Create awareness. I am developing, coordinating, and providing presentations. Wally and Julie were generous enough to give their time, along with Veronica, at the all meeting earlier in August. I'm hoping that we can far exceed the reach 100 people, but later on in this month, I'll be going up to Newtown to do a small presentation to a group of judicial officials as part of outreach, which hopefully we can then bridge into reaching a larger tribal audience. Second piece of that has been meet with members of the legislature, service providers, advocacy organizations to introduce myself, discuss the Olmstead Commission, answer questions. I've tried to make myself as available as possible to persons in the community to be running myself up to speed. I always introduce myself as the person in this room that knows the least about the system, because everybody else has had intimate knowledge, intimate contact with how the system works, and I'm still trying to be a good face for the commission, and I think think 10 meetings is probably low over the course of the year, but over the course of this past year, it's been meeting with NDACP. I went in front of them to ask them about the workforce study that we are trying to do with peers, the UND Research Institute, in conjunction with the DD Council. I went in front of the DD Council, and I hope to do much more of that to put the Olmstead Commission out there as a place for persons to bring comments once they have reached the level, as this senator indicates, of some sort of identifiable systemic issue that we can, as the judges phrased it, shine a light on and develop some more information about. And that also goes into maintaining a public presence. As I said, there was the presentation at all, and there was a presentation at the annual NDACP conference on the Olmstead Commission and Olmstead issues. This also indicates developing and delivering information on Olmstead-related issues to policymaking bodies. Some of that will also go into the white paper topic that was discussed above. And of course, participate in work groups and organizations that focus on home community-based service and Olmstead Commission issues. I try to be intentional on reaching out to anyone that has a meeting, that has some organization that is looking at HCBS to, if not participate, then be a part of the discussion, and then follow up with that individual, that entity, or some of the audience on, you know, how can, if there is something that might rise to the level of an Olmstead issue, how can they come to us and develop that concern into something that can be articulated to the commission? Or just also making it known that we're out there, and if they hear of that sort of issue, they can bring it to us.
This is Julie again. We also did the Olmstead panel at the self-advocacy conference. We did that too.
I'm sorry, because it was all, I was conflating the two in my head, excuse me.
It's okay, but that was good. I think a lot of consumers reached out to you after that too.
Yeah. Some of them are sitting in the back of the room.
Yeah, now they're here, yay.
But that's the kind of thing we'd like to see all of us participate in. I was just one of the voices there, and it's good to be part of that. You know, because they did ask you, why would you even want to be on the commission? So you know, there is an ownership piece that we all have to take. I know one of the next things Dan's talking about is just maybe the report to the governor, and you know, we have Ryan here, who's the governor's counsel, and the governor appoints at each and every one of us. So we need to use that forum as well to say, Governor, you appointed us, here's what we're doing. Keep him apprised of all the issues that we're touching on. So hopefully that's one more advocacy that's important. Because we wouldn't have to do that, you know, unless he inquires, but we're saying, no, let's go out there and actually use that lever that we have and try to help move the needle, even with the governor. So hopefully that'll be good.
This is Carlotta. So the question I would have then, if we, for example, find out that there is an Olmstead issue that needs to be addressed in North Dakota, will we be, as the council, be letting the governor know, shining the light on that, so to speak, so the governor is aware of issues that we're seeing coming up?
We hope to lean into Ryan here a little bit in terms of being co-chair of this particular commission too. So yeah, as issues arise, keep them well apprised of them. So.
And we have a regular cadence just internally with staff, with the governor as well. So if there's an issue, then we can bring that to his, awareness as well. And then the degree to which he wants to get involved is obviously going to be up to him, depending on what that issue or that matter might be. But probably be a case-by-case basis. But certainly if there's something that boils up, then I definitely bring that back to, we have regular policy meetings and then regular executive level meetings as well. So it could definitely be pushed up through each of those levels internally to the governor.
just as an aside, years ago, I was on the Economic Development Foundation with the Commerce Department. And we did a public-private partnership at that time and raised about $1.4 million to promote North Dakota. We called it Find the Good Life in North Dakota. And that particular program kind of went by the wayside, and I understand now it's kind of being reinstated because, as we've heard, workforce is all of our issues, and we need to be better about even promoting our state, with 18 to 20,000 jobs, or maybe it's more, Ryan, I don't know.
Sounds about right, 20,000.
It's a big deal. 20,000 positions are available here, good positions, and all range of service positions. So, that's something that is a governor-led issue as well too. So with the Commerce Department and with our commission and other things. So hopefully we can be a better and louder advocate for all of these things. So Dan, let's lead into your how to push the governor.
I don't know that I want to push the governor. Maybe this is initiate discussion with the governor. But actually, I think that just returns us to the question of, are these goals, annual goals that everyone is comfortable with, comfortable moving forward with?
You're looking for a motion?
However, the chair or the committee or the commission might like to address that.
I missed the last meeting, but was this reviewed at that point? Checking. I don't know this.
We hadn't had the final meeting on it.
Well, I think in terms of what's been presented, it would really be good if we, as a commission, approved it. So
I would like to make a motion to approve the strategic planning annual goals.
Is there a second to that motion?
This is Scott. I'll second it.
Okay. Let's see, I'll let Scott do that, but thank you, Shimon. Is there any further discussion?
Are we taking public comment on this, or on our plans and goals, or not yet?
I think they can have their inputs, but in terms of approving them, I think it's something that we've worked on with in the committee structure and other things too. So, and it's one of these things where we can amend this as we go forward. I mean, I would hope that every year is a new set of goals and watch what our work plan is requiring each year. Well, the motion has been made and seconded. All those in favor signify by saying aye.
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 Opposed, same sign. Okay. Thank you. Appreciate that bit of work. And Scott was one of the members of that committee, and we certainly appreciate his inputs. Thank you, Scott. Veronica's not here today, but she also is very, very helpful in the way this is actually formed. So. Now, Dan, the coordinator updates, a lot of that was discussed in this previously. Is there anything else you want to talk about in that?
I can fill in the activities of the consultants that we're employing on the professional survey, on the Olmstead plan revision work, and some additional notes on white papers. Actually, I would like to have some further discussion on some of these points. This might be a good time to take a brief break, and we can return to this and then have a 25-minute to half an hour discussion to close out the session.
Okay. It's 3:25 right now. If we come back at 25 to 4, let's take a 10-minute break, and we will have more public comment as item number 9 is all part of that too, so we'll look for that too.
Good deal.
Take a quick 10-minute